Hello, everyone. Thank you for all coming along to our open prescribing session today, getting the most out of open prescribing for finance teams. So today we're talking about openprescribing.net. If you haven't gone there, please go there. It's on the internet. It's openly available. And I'm going to give you a live demo, show you the bits and bobs around the website that you may not have come across before and really get the most out of it for you and your teams. But let's start. What exactly is the data we're showing on the website? So some of you may recall these green prescriptions that you can see here on the screen. You may have held one in your hand. You may have been given one yourself. You may have given one for your children or your family members. Mostly these are all electronic these days. You don't actually get to hold a prescription like this in your hand. Over 90% of prescriptions are electronic, but helpful to think of it in this way. What we have in open prescribing is the end of the prescription process. So a doctor writes a green prescription like this, and nowadays it's more than doctors, it's nurses, pharmacists, and many others who can write prescriptions. That prescription is taken to a pharmacy where it actually, although it's a legal prescription, you can also think of it as a check, because the pharmacist gives out the medicine that has been ordered by a doctor, and they send that green prescription to Newcastle, to an organisation I'm sure you're all very familiar with, the NHS Business Services Authority. So every single prescription from pharmacies end up in Newcastle, where they are scanned, or they were in the old days scanned in the largest scanners in Europe, but nowadays they all flow in electronically. And the NHS BSA pays every single pharmacy for that prescription, what that pharmacy has provided to a patient. Now, as a byproduct of that, we have a huge amount of data sitting in NHS data stores in Newcastle. We have the NHS number of from every prescription. We've the name of the patient. We've got their age. We've got what medicine was supplied, but the pack, the quantity, how much was paid, and which doctor, which GP surgery gave it out. So that is a huge amount of data, and a lot of that data flows around the NHS. But one thing, what we use in open prescribing is every single month, the NHS BSA takes a subset of that data and publishes it openly on their website. And it basically has the GP's name, the practice, as opposed to GP, but the general practice, as opposed to general practitioner, practice name. It has what medication was applied. So let's say a atorvastatin 40 milligrams, and then tells you how much. So 28 tablets, 56 tablets, and tells you how much the NHS paid for that medication. And it's all there on a lovely BSA website. And it looks like this, which is open in Excel. Oh, that might be a Google team sheet. And in the old days, it was even so big that most NHS computers couldn't even open the file. I think we've moved on a little bit now. But at Open Prescribing, we take that raw data and we turn it into a beautiful website that anyone in any practice, any member of the public can go and use to see what GPs are prescribing, audit their own prescribing if they are a GP, identify places where they can save money. Open prescribing, that's what we're going to go to right now on the internet, but we just give some context. There's 20,000 unique users of open prescribing every single month, mostly people from the NHS. From the analysis we've done, we don't collect too much data, but we know mostly it's NHS people, but we know members of the public, media, etc. use it as well. So at this point, we are going to hopefully switch to a live demo of open prescribing. So I think most people here are from ICBs or local NHS organisations. Go through it there. I know there's a few people from national organisations. We can talk about that as well. But the main thing, and the thing we push everyone on open prescribing, is practice and area dashboards. So we have built, using prescribing data, practice and area dashboards for every practice, PCN, ICB, regional team in England. And I think we'll start off just to show you how it works, but all the dashboards work the same. We will start at ICB. So Sub-ICB location is basically the old CCG footprints. So they're a bit more refined than the ICB. So it gives you more local information. People can't talk. Chris, do you want to volunteer an ICB that we can look at? So people can...
Yeah, we have some people from West Yorkshire ICB today, so that might be a good one to start with.
Okay, we'll have a look at West Yorkshire. I know you guys didn't. So actually, I should use my. So here you can search for. Anyway, so we've got East Riding of Yorkshire, North Yorkshire, and Vale of York. So I'm just going to go North Yorkshire. I know it was West, you said, but we'll pick the one that's there. So every practice PCN ICB dashboard looks like this. You get name of the organization, who are the constituent members of that organization, and you can see them if you want, who closed and dorm ones. You get a little map of where you are in the country. Doesn't really matter ICB level. At practice level, there's a lot of Dr. Smiths around the country, so you want to make sure you've got the right one. We'll come back to this, but this is our main place where we push people, because this is what people find most useful, is standard measures of prescribing quality, safety, and cost effectiveness. And then we have some more dashboards, and we have some email alerts that we will come to later on. So first off, open prescribing measures. This is the standard way a measure looks on open prescribing, and we've got over 100 now of measures of prescribing quality, safety, and effectiveness. So the number one is always the one that's most outlier for the mean, but let's click in here and we'll look in more detail. There. So here are the 100 measures. So you click in here, and this is how you start to review your prescribing. So for every measure, it looks the same. The red line is your organization. The dotted lines are deciles of organization of your peers, so split into 10 across the country. And then the more solid blue line is the English median. So here we can see this is items which should not be routinely prescribed in primary care. All items, this is otherwise known as the NHS England low value medicines or do not prescribe list. So in North Yorkshire, they are prescribed more of these compared to the English median and their peers. So if you're in an area, North Yorkshire locally, they can now set about going, okay, how do we go and fix this? But they can see they're an outlier for the peers. Similarly, here, so there are NSAIDs. These are your common painkillers like ibuprofen, non-steroidal anti-inflammatory drugs. There are certain ones that are recommended, certain ones that aren't. So in open prescribing, generally low equals good. So you want your red line to be low. In North Yorkshire, they prescribe more of the non-recommended NSAIDs compared to their peers. Now you look at the Y value, this is percentages. We never expect zero because we're all, you've diverse patient groups. We always expect that some people will get things that aren't recommended for the whole population. However, this gives you an opportunity with open prescribing to compare your prescribing to your peers. Now, everyone says, oh, it's too much data, too much data. What we've done on open prescribing is we've organized things where you're an outlier from the median. So here, you're an outlier. These are things that are really high. So I'm not pointing out really bad practice here. But we can go in North Yorkshire compared to here. They are really low. So these are things that comparatively compared to their peers on the things that NICE, etc., say they're doing a bit better than their peers. Remember, this is talking about population level. For every individual patient, they'll have their own circumstances, and there may be good reasons why NICE guidelines aren't followed for an individual patient. But if we look here, this is prescribing less environmentally friendly meter dose inhalers. So it's a lot of work around greener NHS, which is good for the environment, and quite often, I'm led to believe, saves money for the NHS. Here we have North Yorkshire is the lowest. They're in the 4th percentile, so they've done really good. But here's a really nice thing that we can see here. So they were around the English median, but you can see in September 2020, they start to divert. They start to do something, and particularly here around August, summer of 22, something happens and there's huge changes. So I think this, and based on my experience of looking at a lot of these charts, is this ICB, someone there has done something. Maybe ran an education session, maybe have local quality incentive scheme to get practices and people to switch to prescribing habits. And we can see that change happening there. If you are more interested in, let's say, what are we interested in? Any particular, if you're an antimicrobial stewardship group, you can look here. As your finance teams, you may be working with different groups. You may be working with the Meds Op team. You may be working with the cardiovascular disease team, the population health team. So there may be times where you want to just go and look at those directly and look at cost saving measures. I'm sure you're all doing QIP or SIP plans or whatever the local terminology is for these things. We've things that range there as cost saving, and you can then measure and track things as we go. So going back to the NHS England do not prescribe list. So lidocaine plasters, I think that NICE and NHS England do not recommend. So for every single measure, again, we're not expecting everyone to remember these things. We have a why it matters to an individual GP and patient at the coalface. So you can say why they don't recommend lidocaine. You can get links to more evidence, and sometimes there's patient information leaflets here. We've links to the full NHS England document. You can see here if this ICB had prescribed in line with the median, they would have, say, spent £55,000 left. So that's a cost-saving measure. But also, lidocaine plasters, there's no evidence to suggest they do actually work. But so what? You have to go and do something about it. So then there's a few things you can do. We can then explore further what's happening. So generally here, you'll want to look at, well, which individual practices in my area. It might be which ICBs in your area you're looking at. You don't know, but you can see then which practices. Sometimes, not always, but sometimes it might just be one or two practice surgeries, one or two PCNs that are driving a very high outlier measurement in an ICB. So you can go there. You can see the measure on what actually individual presentations. So here we're talking about lidocaine plasters, so it's all going to be plasters, but we can see how they're prescribed. So most of the variation is prescribed by lidocaine plasters, which is generic prescriptions, but also in this area they prescribe Ralvo and Versatis, which are the brand name prescriptions. So here we can see then. So you can go locally, work with teams, probably not yourself, but there'll be teams in your ICB who can then go and identify those prescriptions, which practices are using them, and then help support patients to reduce the prescribing, maybe find alternative painkillers, and maybe find referrals to other services who can help with their pain. Right, that is the standard measures. However, we'll go back to the main dashboard. So next thing I want to show you is price concessions. So the NHS drug tariff determines what is paid to every single pharmacy every single month, and that comes out just before the end of the month. So in the last week of August, the September drug tariff comes out. And generally, that is a finalized list of prices. However, there are a thing called price concessions, formerly known as no cheaper stock obtainable. And this is when in month, pharmacies start reporting to Community Pharmacy England, who are their representative body, that prices have gone haywire for a particular drug or they can't get the drug. Community Pharmacy England then have a process with the Department of Health and Social Care where they can negotiate in month new prices. And then in the last week of the month, generally, there are new prices for certain preparations released. And I'm sure in some of your areas, you then, an analyst in your area, some of the meds op teams spends maybe half a day getting them, looking up the previous price in the drug tariff, working out how much you prescribe, and then does some estimate for some committees in your area, because this can actually have a huge impact on your budget bottom line. We've developed a dashboard that within minutes of the new prices being released, you can see how much the impact is estimated to be. So we can see here, and this is August, the projected additional breakdown for this area is 330,000. We can then see for each individual preparation what the additional impact is. And then probably the most helpful thing, and encourage you if you're in ICBs to sign up, is you can get an email direct to your inbox that tells you how much we estimate the impact is going to be on your particular area of NHS price concessions. And that will save a lot of analytic time. So I'd encourage anyone who hasn't seen this before to sign up here to save time and start to monitor the impact of these price concessions. As you can see, they are cyclical, but we do seem to have a sustained increase over the last year and a half. But generally, the pattern follows this sort of low impact, then it'll jump for a few months and then go back. But we have to see it's quite low and it's starting to trend upwards in the last few months. The next thing I would like to show you is our price per unit tool. So this is a tool that we built to work out savings based on how things are prescribed. So traditionally, it used to be really easy. NHS prescribing advice was to doctors, prescribe generically, that's the safest and it's also the cheapest. So you prescribe a atorvastatin, which is the most common statin, instead of prescribing the brand Lipitor. As the years and decades have gone on, things have got a lot more complicated. There's things like branded generics you may have heard of. Sometimes tablets are cheaper than capsules. Sometimes liquids are cheaper than tablets. So it's become very, very complicated. So we wanted to work out a tool to support the NHS to work out what's the most cost efficient way of prescribing something where the patient ends up with basically the same chemical substance. So for example, here, and we look at, there's lots of things, melatonin, 2 milligrams modified release. So this is a capsule tablet switch. So I can see here for the formulation swap. Now, our tool works out the price per unit. So for each tablet or capsule in North Yorkshire, they pay 24p. The target PPU, so this is what the most cost efficient 10% spend is, they only spend 13p for 2 milligram modified release melatonin tablets. We worked out if NHS Yorkshire spend in line with that, they would spend 13p and they could make savings of £7,000. That might not seem a lot to you, but overall, when we work it all out, you're close to £500,000 savings a month. Not all of these are realizable. I'll come on to in a minute. But if we click in here, we can see North Yorkshire. So we can see they prescribe a lot of Circadin 2 milligram modified release tablets. And that's 51p per tablet. Where if you prescribe it all generically, it would be much, much cheaper. And we can see across the table in England, this is the pattern of prescribing in England. So few people do use capsules. Now, coming back to what I would say is this tool is an area for exploration of potential cost savings. They're not all fully realizable. If you're from a national organization, I'd say get in touch with us. We can talk you through more of the ins and outs of this because we're essentially capitalizing on inefficiencies in the NHS drug tariff to work out these savings. And we've written about it here. We actually think fixing some of the inefficiencies in the NHS drug tariff would be a better way of going about it for national organizations. But for those in local organizations, you may want to use this tool to help inform discussions with your meds op teams when you're producing saving plans. Some of these savings will be realized, but some of them won't. For example, even these price you're paying, sometimes you may have local rebate schemes in place. Sometimes you may have, for good reason, decided to go with a particular brand of inhaler rather than another one. But this tool is available. It's very helpful. People who use it tell us it's helpful. We have, and if you want to read it here in our paper, we did a trial against people who used this tool, people who didn't, and people who use this tool prescribe more cost effectively than people who don't. So we think it's a useful tool to have to help inform discussions locally when you're developing plans. Ghost branded generics are a thing that I'd encourage you, if you have a saving on your page, go and look at it. Half the pages in the country will have a £0 saving, half will have a substantial pound saving. So North Yorkshire could save about £10,000 a month based on ghost branded generics. Please go and have a look at that if you have a saving there. I won't say much more about it. And then the final thing to say about organization and practice pages. This is probably the single most best thing you could do to encourage colleagues is to sign up to your organization's alert. So every single month, so it's really easy for people to send out newsletters about what's happening about the tool or what they're good at, what they're bad at. What we do on OpenPrescribing, we use some fancy pants data science to develop a bespoke email alert for every single practice, PCN, ICB in the country. And you get a bespoke email of your prescribing habits every single month. We have what is good about your prescribing, what is potentially bad about prescribing. And again, these are all subjective, but it's helpful to start conversations. But it also tells you things about when your prescribing measures are getting worse or when they are getting better. So it acts as an early warning system, so to alert you to changes in your prescribing. So we have that over 50% of practices are subscribed. I think 90% of ICBs and lots of PCNs. We have 5,000 email subscribers to this alert every single month. I think of all the things you can do, maybe we could talk about in the Q&A session. I'd say sign up for your own organization's alert, and then every single month you'll get an idea of how your prescribing is progressing. Now, let me show you a few more things. So first off, we've shown you pre-specified measures of prescribing. You may be interested in all sorts of different things. So we have our Analyse page, which allows you to query the whole prescribing data set. So if you're interested in, let's say, simvastatin, which is one of the most common cholesterol drugs, you want to look at it in your ICB. So let's go North Central London, where I used to work. You can show your data here. And it gives you of all the simvastatin prescribed in North Central London compared to all your peers. Below the table, it gives you breakdowns of what was the spend and the amount in the last month, what was the financial year to date, what was in the last 12 months. If you're interested in monitoring a certain drug, you can sign up to email alerts and get that every single month. As well, just wording this, so simvastatin, that's just the complete count. Sometimes we like to put denominators in to give a fairer comparison. So for example, you might want to check your list size in there. So that's for every patient registered with a GP practice in your area, and that's a control, a denominator, just to control for different sizes, different patient numbers and ICBs. So North Central London was amongst the highest prescribers of simvastatin at an absolute count. But you can see here when we put the denominator here, they use a lot less comparatively, and that's because North Central London has got a huge young population who wouldn't expect it to be on statins. So there we can use perhaps a different denominator to control for some of the variations. So out of all lipid regulating drugs, which is the fancy pants name for statins, how much simvastatin do North Central London use compared to everyone else? So we can see here, they're sort of bang in the middle there. If you would like to look at a specific practice, you can. So Islington Central Medical Centre, I know, is in North Central London. So there you can go and look, and it will compare that practice to all the other practices in the ICB. If you can't remember what practice you just like to see practices, at the Sub-ICB location, you can put in your ICB. So put practices, and then you can put North Central London, Sub-ICB location. This will give you a chart with all your practices data on there. So you can see all the practices in North Central London. What is their simvastatin use as a proportion of all lipid regulating drugs, aka statins. You can get emails, you can get breakdowns there. And that is our Analyse page. I encourage people to check that out. And then I'll just show you, finish off one or two few things. So if you are just interested in chemicals, a BNF section, if you want to just see nationally, so we've got the complete British, so I should say the British National Formulary. Sorry, I apologize. I used to dealing with nerdy meds up folks who have heard of the BNF. Some people might not have. So the British National Formulary is a large book, although it's all online now, purchased by NICE, developed by the Pharmaceutical Press, and it's made available by NICE on their website to the whole NHS, and it basically has every single drug in there, and it's got chapters, paragraphs, etc., where they divide drugs up in. So it's a useful classification system for drugs. So we can see here spending across all practices in England. We can see all items in England. If you're interested in a particular drug, semaglutide, I read a newspaper article. This is BNX session. So if you're interested in drugs used in diabetes, see there. If you're interested in, for example, insulin, you can go and have a look there, and you can get into the data much more and have a good explore, and you can explore the prescribing trends in your ICB location as well, if that's useful, if you need charts for a particular meeting. The drug tariff that I mentioned before, which is every price. If you just want to look up prices and concession prices, you can do that there. And to finish off, I will just show you our improvement radar. So we've looked at prescribing measures. And you may be having local discussions about, oh, can we improve this? Can we save money here? And people might be saying, oh, it's really hard. I'm not really sure how we'll do it, or this is impossible. And it might be really hard. It might be impossible for specific reasons in your area. But what we do in prescribing on our improvement radar, we've developed some data science algorithms that work out, is there any patterns in the data that are suggestive of areas that have implemented an improvement program? And we work out that every single month, We then upload it to the website, the areas we've identified that are suggestive of an area that's improved their prescribing over a very short period, suggestive of a really targeted quality improvement campaign. So let's look at some antimicrobial stewardship ones. There's lots around here going. All the cost-saving ones we've mentioned are here. You may be interested in particular ones. Go have a look, but I'll just stick to this antimicrobial stewardship one. So antimicrobial stewardship. So we are, the public health professionals describe antimicrobial resistance as the silent pandemic, worse than COVID. It's going to kill us all eventually. And there's a lot of work going on to avert this catastrophe over the next 10 to 20 years. And one of the things in terms of improving our stewardship, how we use antibiotics, is to reduce the amount of time that we give antibiotics for, because actually short courses of antibiotics generally are just as effective as 7-14 days. So amoxicillin, one of the most common antibiotics used for things like chest infections, NICE recommend in most cases, for most conditions, it's used for 5 days. So you give one amoxicillin 5 mg 3 times a day for 5 days. That's 15 milligrams. Historically, sometimes in some guidance, you would have had 7 days, 14-day guidance, even for some things, 28. But here, using OpenPrescribing, we can work out who's giving more than 15, and people can monitor their prescribing, because that suggests they're still going by old guidance or aren't as attentive as we would like to prescribe in 5-day courses. And here we can see NHS Calderdale, huge drops. So they're actually above the English, way above the English median. They came down here, flat along these, massive change here. NHS Warrington, over 80% of the prescriptions were for more than 5 days. And suddenly, in mid to late 2023, someone did something, bang, they came down to the national median, coasted along for another few months, bang, something else happened here. So across Warrington, probably in 2 phases, they had a very, very, very successful targeted quality improvement program. And we have that from, you see NHS Devon here, huge drop, 80% in early 22, right down to some of the shortest courses across the whole country. And you can see this for every single measure. You're probably like, oh, this looks easy, just look at a few charts. But we're doing this for every single practice, every single PCN, and every single ICB. That is tens of thousands of charts, if we got my maths right. And we do this with a computer every single month. In a few minutes it takes to run this algorithm, and then we can identify who is prescribing, improving in sort of a targeted way. And we've put this on our website just to help inform discussions locally. You may go to colleagues, you may have a look and say, oh, we're doing this thing on lidocaine plasters. You go and find what's happening in another area, and it can be another helpful thing to see what other people are doing. And it gets away from the what good looks like approach across that. I'm familiar with the NHS, as everyone just asks their mates, are you doing something good on this? Are you doing something good at that? And you've no real way to appraise, is it really that good that they're doing? Is it really not? This is a sort of data-led, data-driven approach to identify areas. Might not always be an amazing campaign, but it's suggestive of an area where they're doing some good targeted work. And that's all the features of OpenPrescribing.net. If you want to know more, please have a look at our website or get in touch via email. See you soon.